Hello, can you hear me? Yeah.
Yeah.
So at this outset, I'd like to thank Karthikeyan sir for this opportunity given to me. So I'll be covering on paced ECGs, just the basics for PGs to understand as to how to interpret a paced ECG. So I'll start off with this. A 65-year-old gentleman underwent a single chamber pacemaker and came for follow-up. So this is his ECG when it comes for follow-up. So this is a paced ECG, and for beginners, for PGs, and mainly for physicians, paced ECGs are always intimidating. We don't understand what is there, so it's always difficult to interpret a paced ECG vis-a-vis a normal ECG. But it need not be the same. If you can understand how a pacemaker works, it's very easy to understand or interpret a paced ECG. So the whole idea of my talk would be to put across the same thought as to what to expect from paced ECG and what you can interpret from a paced ECG in the next 10 to 15 minutes. So coming to the basics of pacemaker system, we all know this fact that a single chamber pacemaker has got a single lead which can sense and pace the chamber of origin. So suppose it's a ventricular based pacing, it senses and paces the ventricle. If it's an atrial based, it senses and paces the atria. A dual chamber has got two leads, one in the ventricle, one in the atria. The atrial lead senses and paces the atria, and the ventricular lead senses and paces the ventricle. So what you realize is the basic difference between a single and dual chamber is in a single chamber, the atrial activity is not sensed or paced. So you will not have any relationship between the atria and ventricle. Vis-a-vis a dual chamber, there will always be synchrony between the atria and ventricle. This is one thing we should realize when we see what paced ECG. So another important thing is to identify what a pacemaker does. So unlike common understanding that pacemaker is not just meant for pacing, it has got another very important function, that is of sensing. Sensing is as important as pacing. So pacemakers do something called as a backup pacing. So it paces only when it's required. So what the pacemaker leads do is they sense for intrinsic events. And if there are intrinsic events, it will just keep quiet. In the absence of an intrinsic event, either atrial or ventricle, it will give up a backup pacing. So sensing is a very important part. And this is very important to understand that many of the times, even though the pacemaker is implanted, it might not be pacing because there wouldn't be any need for pacing. There's an intrinsic sensed event happening. So another important thing that we need to understand is some of this conduction system disease may be intermittent. So when you plug in a pacemaker at the time of implant, the patient might not have any intrinsic ventricular event. He might be in a complete heart block, but this could be intermittent. And on follow-up, his AV conduction would have recovered a little bit. And during that time, when there is a recovered AV conduction, the pacemaker wouldn't pace because, as I told you, the pacemaker would sense there's an intrinsic event and just keep quiet. In the absence of an intrinsic event, it will give up a backup pacing. So if you understand this concept, I think it will be very easy for PGs to by a paced ECG and interpret a paced ECG. So, in a patient with a dual chamber pacemaker, 4 possibilities are possible when you see a follow-up ECG. One, if the intrinsic atrial activation and AV conduction is present, like you've put it for an intermittent AV block, and during interrogation, his sinus rate is good. So he has got good intrinsic atrial activity. He doesn't require atrial pacing. And his AV conduction is also improved. So he doesn't, he's got intrinsic AV conduction at the time. So he doesn't require any AV pacing. So at this point of time, what the pacemaker does, it just senses the atria and senses the ventricle. There's no need of pacing either the atria or the ventricle. So what you get is an atrial sensed event and a ventricular sensed event. On the other hand, if the intrinsic atrial activation is absent, but AV conduction is intact, imagine putting a pacemaker for a sinus node dysfunction. The intrinsic heart rate is around 40, and you put in a dual chamber pacemaker and program it around 60. So the atria keeps on getting paced at around 60. So there's atrial pacing happening, but all the paced event gets conducted to the ventricle because the AV node is normal. So, there is no need, even though you have a ventricular lead, the ventricular lead doesn't have to pace the ventricle because the AV conduction is intact and all the atrial events get tracked to the ventricle. So in this case, what you're expecting is an atrial pacing, but a ventricular sensing event, or what we say is AP and VS. The third possibility is atrial activation is intact, but no AV conduction. This could be a typical scenario of a complete heart block, permanent complete heart block, wherein you have good sinus rates. So the atrial lead just senses the sinus rates at all, just senses the sinus. It doesn't pace the sinus because there's no need. On the other hand, because there's no AV conduction happening, the sinus, P waves do not track to the ventricle. In that event, this pacemaker senses that there's no intrinsic activity, and instead it paces the ventricle after time interval, which is again programmed. So what you get is an atrial sensed and a ventricular paced event, or ASVP. And the last possibility is the patient has got no intrinsic atrial or ventricular event in ventricular conduction at all. He is having a pan conduction system disease. He's got very poor sinus rates, and none of the sinus events are conducted to the ventricle. In which case, what you expect is an atrial pace and a ventricular paced event. So these are the four possibilities that you see in what you expect in a post pacemaker ECG. So the information that we need from a paced ECG is One, whether it is single or dual chamber pacing. Second, whether it's pacing properly. Third, possible site of pacing. That's another information that you can get, not necessarily, not absolutely essential, but you can get that information. Fourth is sometimes in diagnosing ischemia. Now, as I told you, the basic difference between a single chamber and a dual chamber pacemaker ECG would be that the atrial and ventricular events are not in sync in a single chamber. So if you find in a paced ECG that the atrial events are dissociated from the ventricular events, this patient is having a single chamber ECG. Pacemaker. So if you take this example, so you can see this pacing spikes. These are unipolar pacing spikes. So these earlier what pacemakers had this large unipolar programming just to make the physicians aware that there is a pacemaker implanted. But most present-day pacemakers are programmed in bipolar mode, and these pacing spikes are really very small. So, but what you see here is there's a pacing spike, and the pacing spike is capturing the ventricle. It's capturing the ventricle. That's why you have a QRS. So since this pacing spike produces a QRS, this your pacing is the ventricle. So if it produces a P wave, you're pacing the atria. If it produces a QRS, you're pacing the ventricle. So here you're pacing the ventricle. Which ventricle? Would be the right ventricle, because most often we pace the right ventricle. And the easy way to identify is if you're pacing the right ventricle, you capture the right bundle bunch first, causing an LBEB. If you're pacing the left ventricle, you capture the left bundle first, causing an RBEB. So here you're capturing the right ventricle, and the pacing is consistent at around 60 beats per minute, around 5 squares. So it's pacing regularly. And now you know that there's a pacemaker lead in the right ventricle which is pacing regularly at 60. What about the atrial event? Is there any atrial lead? For that, we need to see at the atrial event. If there is an AV synchrony, most probably this is a dual chamber pacemaker. But here you don't see any timed atrial event. Instead, you see some small retrograde P waves. So most likely this patient is having a single chamber ventricular based pacing. And if you see further, 2-3 AVF is upright. So maybe the lead is somewhere near the outflow tract. If the lead is typically positioned in the apex, you will have 2-3 AVF negative and 1 AVL positive. If 1 AVL is negative and 2-3 AVF is positive, most likely this is slightly towards the outflow tract. So the information we get here is this patient is having a single chamber pacemaker, RV ventricular based pacing, most probably pacing in the outflow tract, set at around 60 beats per minute, and it's working perfectly well. So much information you get from this one ECG. As I told earlier, sometimes we need to be careful about the spikes because the QRS morphology, especially now with the present physiological pacing, the QRS might look absolutely normal and narrow, but only closer observation will reveal that this patient could be having pacing spikes. So, this bipolar spikes are slightly more wider than this, but sometimes in the new physiological pacing, the spikes really have to be looked into, and it's easy to miss a post-pacemaker ECG. So going further, going through a few ECGs. So if you look at this pacemaker ECG, this is again a pacemaker ECG because you see a pacing spike, and the pacing spike is producing a QRS, so it's obviously capturing the ventricle. This is a lead in the ventricle. The ventricle being paced is the right ventricle because you get an LPEB. And the position in the right ventricle is probably the apex because you have 2-3 AVF negative and 1 AVL positive, and also this late transition. So probably we are pacing the right ventricular apex, and the pacing rate is around 60 per minute, because there are 5 squares between 2 pacing spikes. So this much information we know. What about the atrial chamber? Is it paced or sensed, or is it just left as a single chamber? For that, we'll have to look into the atrial events. You can see that the atrial events are totally disconnected from the ventricular events. So most likely there's no synchrony between the atrial and ventricular events. This patient is probably having a single chamber VVI based pacing. In a VVI, the first is the chamber paced, second is the chamber sensed, and last is the action taken. So it is inhibited. So if you see this ECG, you have a pacing spike. The pacing spike produces a P wave. So obviously you're pacing the atrium here. So, it's pacing regularly at around 60 beats per minute. Now the P waves are conducted to the ventricle, producing a narrow QRS, which looks like an intrinsic QRS. So, what we understand from here is there is an atrial based pacing for a probable sinus node dysfunction because there is no intrinsic activity even at 60. There's only based atrial activity. And this sinus P waves are conducted to the ventricle in a 1:1 fashion. So the AV conduction looks absolutely normal. So this patient probably has a sinus node dysfunction programmed in either an AAI or a DDD mode. So this patient could very well be having only an atrial based pacemaker, rarely put, or he could be having a dual chamber pacemaker, but the ventricular lead is not required. It's not pacing here because what the ventricular lead does is just senses. Moment it sees intrinsic activity, it holds back. So it doesn't show up on the ECG. If the intrinsic activity fails for some reason, then it will pace the ventricle. So in this ECG, you have two pacing spikes. So the first pacing spike produces a P wave. So it's an atrial pacing spike. So there's an atrial lead for sure. It is producing a P wave. But unlike the previous ECG, the P waves generated do not travel to the ventricle. For some reason, they don't travel to the ventricle. Instead, the ventricular lead waits for some time. That's called the AV delay. And when it doesn't sense any intrinsic ventricular event, it gives a pacing spike in the ventricle also to generate a ventricular event. So here you're having an atrial paced and a ventricular paced event. So most likely this patient has a pan-conduction system disease. He's having a dual chamber pacemaker, one atrial lead producing an atrial spike and one ventricular lead producing a ventricular spike. And the fact that both chambers are being paced says that his sinus node and his AV conduction both are diseased. That's why he's requiring pacing in both the atria and the ventricle. So if you look at this ECG, again, it's a paced ECG. The chamber being paced is the ventricle because it's producing a QRS. So the pacing rate is around 70 per minute. But what you realize is, the relationship between the previous P wave, the P and QRS are related to each other. So although you don't see a pacing spike in the atria, the very fact that the P and QRS are related to each other, that means there is synchrony between the atrial and ventricular event, that says that this patient should be having an atrial lead also. Only if there's an atrial lead, the atrial and ventricular events can be synced to each other. Earlier, there was a VDD pacemaker, VDD lead, which could sense the atria, but that's no longer being used now. So now if you see a dual chamber, if you see a synchronized atria and ventricular event, most likely there are two leads, one in the atria and one in the ventricle. This patient obviously doesn't require atrial-based pacing because he's having an AV conduction problem. So because there is no atrial-based, his sinus node is normal, the atrial spikes are not being seen. So the atrial lead just monitors the intrinsic atrial activation. It senses that there are good P waves. And because there are good P waves, it doesn't produce any atrial spike. You only see a sensed events in the atria. On the other hand, because the patient is having an AV block, none of the P waves travel to the ventricle. So since the ventricular lead senses that there are no intrinsic ventricular events and gives pacing spikes in the ventricle. So what you see is an ASVP, typically seen in patients with an AV block. Finally, if you look at this patient, this ECG is completely normal. You have an intrinsic sinus rhythm at around 60 with good AV conduction and good narrow QRS. But this patient could very well be having a pacemaker, like what I said. Just because you have a normal ECG without any pacing spikes, it doesn't mean the patient doesn't have a pacemaker or the pacemaker is not working properly. What we need to understand is the pacemaker's action is only, SOS, only it's a backup. So if the intrinsic activation is not there, then it will function. But on the other hand, if the patient is having good intrinsic activation, the pacemaker, even though it's implanted, might not show up on an ECG at all. So just because you have a pacemaker, you don't have to every time expect pacing spikes. Only in the absence of an intrinsic conduction, it will be seen. So coming to what is wrong with the pacemaker. So if you look at this ECG, this is again a pacing ECG, but prima facie, it looks like there's something wrong with it. There are pacing spikes which are not being captured. So how to interpret this malfunction? So there are four possible outcomes of a pacemaker malfunction, the commonest ones. One is loss of output. In loss of output, the pacemaker generator, the battery gets depleted. It doesn't generate pacing spikes at all. So in loss of output, you don't see pacing spikes because the battery is supposed to generate pacing spikes at around 60 to 70 to 80, whatever is programmed. So in the first one, you don't see pacing spikes. In the second one, there's a problem with the lead. Although the pacing spikes are generated, these spikes do not produce any QRS complexes. So the battery generates good pacing spikes and good output, but because there's a problem with the lead, either a fracture with the lead or it's displaced, these spikes do not capture the ventricle and produce a QRS. So here you see spikes without QRS. Third is sensing problem. So sometimes there is oversensing, wherein the pacemaker, which is supposed to sense the chamber of origin, either the ventricle or the atria, senses some far field signals, senses some myopotentials or diaphragmatic potentials, and thinks there's intrinsic activity and fails to pace. So oversensing results in failure to pace. Undersensing results in unnecessary pacing. So in the event of undersensing, even though there's an intrinsic event happening, atrial or ventricular event, the pacemaker fails to recognize that event and delivers a spike. So if you look at this, what is happening here? So in the prima facie, it looks like there's a problem with the pacemaker. It's not pacing properly. But if you look carefully, the output is at around 60 per minute. The battery seems okay because there are spikes regularly at around 60 per minute. So the battery seems okay. Now, if the battery is okay, the spikes should capture the ventricle and produce a QRS. There are only two reasons why a spike wouldn't capture the ventricle and produce a QRS. One is if the threshold is very high, if the lead is displaced. The second is, for capture to happen, the spike should fall on a non-refractory period. So, we all know the QRS and the refractive period. Up to the end of the T wave is the refractive period of the QRS. So once there's a depolarization, the ventricle is refractory to another depolarization, which occurs immediately. No matter what the amount of stimulation during the refractive period, the stimulus won't produce a depolarization. So, if a spike falls during on the refractive period, obviously it's not going to capture the ventricle. Only if it falls outside the T wave in the non-refractive period, when it's completely repolarized completely, only then a spike will capture the ventricle. So just because you have a spike and non-capture doesn't mean that there is a failure to capture. You have to see whether the spike is falling at a time where it is supposed to capture. So in this patient, if you see the spike here which produces a capture, the spike here which falls on the QRS, there's a native QRS, but the spike doesn't see that, the pacemaker doesn't see that, and it falls on the QRS, which is the refractive period. So there's no capture. Again, it falls on the QRS, no capture. Falls on the ST segment, no capture. Falls on the T wave, no capture. T wave, no capture. T wave, no capture. T wave. So all these spikes that you're seeing are not capturing because it's falling on the refractive period. So this is not a failure to capture. The problem here with the pacemaker is it's not sensing an intrinsic event. In the first place, the pacemaker shouldn't have been pacing here, because there's an intrinsic QRS happening here, there's an intrinsic QRS happening here, there's a good native conduction happening. There's a normal P wave and a QRS, there's a good native conduction happening. So in the presence of a native conduction, the pacemaker is not supposed to fire. So here the pacemaker is firing. Unfortunately, those signals are falling on the refractive period, and that's why you have non-capture. So our initial diagnosis was this patient probably has a failure to capture. But now when we understand and see the ECG, we realize this is unnecessary pacing. Or what we say is undersensing. The pacemaker is failing to see an underlying intrinsic event. It's not sensing an underlying intrinsic event, and that's why it's producing it has failure to capture. So here the failure to capture is just because it is falling on the refractive period and not because of anything else. So this patient should not be diagnosed as failure to capture. This is rather as undersensing. It's not sensing the intrinsic event. So if you look at this ECG, here you have pacing spikes. The output is irregular. You can see that sometimes it's around 45, sometimes it's very rapid. So, and sometimes it's around 90. So the output is not stationary, it's very irregular. This gives you a clue that probably the battery is depleted. Second is there are spikes without capture. So is this true loss of capture, or is it pseudo loss of capture because it's falling on the refractive period? So for that, we'll have to see where the spikes are falling. If you look here, the spikes are falling at a time wherein there is no depolarization at all. So the last depolarization occurred over here. After that, the entire ventricle is supposed to be repolarized and in a position wherein a spike should generate a capture. But here, you're seeing clearly in many areas, spikes are not generating a capture. So obviously there is, in this case, there's lack of output and there is failure to capture. Both things are happening. So this most likely is a depleted battery. And intermittent capture is seen. And what you realize is the patient's, there doesn't have intrinsic rhythm. He has got a complete heart block and he's got a QT prolongation. This is the risk that Dr. Mukund was also saying, that sometimes you have sudden bradycardia and complete heart block. You will have, QT prolongation, and which can in turn produces a torsades. So here clearly you have loss of capture and loss of output, probably because of battery depletion. So coming to this ECG, the ECG which I put up in the beginning. So again, if you see here, there is a pacing spike here, but the pacing spike is falling on the, one thing is the pacing output is regular at around 60 per minute. So the battery seems okay. It is producing 60 spikes per minute. So it seems okay. Second is, why are the spikes not capturing? So if you look at the spikes that have not captured, they're either falling on the T waves or falling on the ST segment or falling on the QRS. Spikes that follow outside the T waves are producing a QRS. So it's just that the spikes are falling in the refractory period. That's why there's lack of capture. When the spikes fall outside the refractory period, there is clean capture. So here again, the problem is, although you see spikes which are not being captured, the problem here is because it is not sensing the underlying event. In the first place, there shouldn't have been a spike here because there's an intrinsic event. So, in the presence of an intrinsic event, the pacemaker should just take a back seat and not produce a spike at all. So here, the very fact that the pacemaker is blinded to an intrinsic event says that it is either programmed in a VOO mode, wherein it's blinded to intrinsic event, or the patient has got a problem with undersensing. The pacemaker doesn't see an intrinsic event. That's why there is, unnecessary spikes which produce lack of capture. So here, the problem would rather be with the sensing of the pacemaker than with the pacing of the pacemaker. Most likely, in this case, the patient has been programmed to a VOO mode. So here you can see that there are spikes.
Excuse me, sir. I'm extremely sorry for the interruption. There are 2 minutes left for the presentation.
Yeah, I'm almost done. So here you can see that there are spikes which produce capture. But over here, you don't see, you're expecting a spike, but you don't see anything. Most probably because it has oversensed something. It has oversensed an atrial fibrillation. The ventricular lead has oversensed an atrial fibrillation and thought it's an intrinsic ventricular event and has failed to capture. So, these are the main, problems that we face during programming in a follow-up patient. Finally, coming to paced ECG and ischemia, it's always a difficult subset. Diagnosing ischemia and paced ECG is very difficult. Sometimes because you're producing an LBEB, you can follow the Garbosa's criteria of ST depression in precordial leads and concomitant and discordant changes. But most often, you would rely on the enzymes to diagnose ischemia in pacemaker patients. Yeah, for want of time, I would like to stop here. Thank you so much. If there's any questions, I'll take it.